All right, so let's move on to HER2 positive disease and talk a little bit about that. ER positive disease. And I guess that the first question is, let's just say, because most of the action in this has really been in postmenopausal women, although we'll talk about premenopausal in a few minutes. So a postmenopausal woman comes in, what's your go-to regimen for, say she has a few bone metastases? What do you usually treat people with in postmenopausal?
And she's hormone receptor positive.
Yeah, she's positive,
HER2 negative.
HER2 negative.
HER2 negative. Oh,
Yeah.
certainly an AI, such as letrozole or anastrozole, first line.
Is it
Absolutely.
de novo? Has she
No, let's
received?
just say she had, let's say she's and this is a very common scenario. We should probably talk about this a little bit. She had her 5 years of an AI, and now it's 2 years. So her AI finished in 2010 or 2011. It's now 3 years later, and she has a bone met. And this is turning out to be a more and more, at least in my practice, a more and more frequent occurrence. It looks like we've just pushed, instead of curing
And
people,
she-
we may have pushed out the limits a few years.
And she had a disease-free.
Interval about 3 years. So what would you do?
Well, she's again. I would give her a hormone-based treatment, and I would consider I would consider her for everolimus plus exemestane if she's had 5 years of an AI.
5 years. Okay.
Yeah.
I would give her either the AI alone, re-challenge her with the AI. This is assuming we don't have a trial, of
No
course.
trial. Assuming we're not going to talk about. We'll talk about that in a
Exactly.
few minutes. Assuming no trials.
And I would discuss with her the data of AI combined with fulvestrant. We have 2 trials now that gave us completely different results. The FACT study and then the SWOG study in first-line ER positive, showing that fulvestrant plus an AI led to a better survival in one study and no difference in the other study. And I think these data are important to discuss in patients who have not received a prior SERM, tamoxifen, because that's where the data seems to be more persuasive in terms of benefit. The studies are different in the way that we treat patients in terms of fulvestrant now, because those studies weren't designed with the high dose, loading dose regimen of fulvestrant, a la the CONFIRM study. So I think it's important to share the data with the patients, but I've had some patients who have done that approach who had nice long disease-free intervals after the 5 years of an AI, so 3 years of no disease, and they've just had beautiful responses to this therapy. So the one problem with doing that is that it makes them ineligible for a future clinical trial.
Right, that's the problem, right?
Yeah.
Right. Oh, any comments?
It's interesting that you bring up the fulvestrant AI combination question. It's being studied, as you know, in the higher dose fulvestrant, and I think that that's going to be really useful for us. I have only used that in patients with de novo metastatic disease, and one of the problems with that group of patients is some of them have biologically very aggressive disease, so then they don't respond to any hormone therapy. But that's where I've used it almost in an isolated way. I would start with an AI probably in that patient because a non-steroidal AI, because they had the non-steroidal AI before and had a long disease-free interval. Rather than starting with everolimus, although I think that that's a very reasonable combination to start with as well. And you could use fulvestrant. It's just, again, we're always thinking about how many lines of therapy and what's the next clinical trial that's going to be open that we can get a patient on. And then I think there may be compassionate use of a variety of agents which are not maybe as clear to everybody that are accessible, and that may be happening more and more with this breakthrough designation from the FDA. It just takes time and effort and money, which nobody compensates for, to open compassionate use studies.
But let me, before we go on to that, because there's some interesting stuff about palbociclib and CDK4 inhibitors, which is what you're hinting at here. But before we go on to that, Terry, do we have data from the neoadjuvant setting with fulvestrant to kind of help us figure out that question of someone who comes in after 2 or 3 years be getting the combo, be getting the AI, the non-steroidal AI, or fulvestrant?
I mean, if they are, I'm not familiar with. I
Yeah, okay.
don't know much of any neoadjuvant trials of fulvestrant.
The newest study, I think, was 500 versus 250 of fulvestrant. It was
Right,
a
it was just-
biomarker study.
It was just a biomarker study, so it really
Yeah.
didn't help us. So we really didn't have a lot of data, and then I think that, again, in practice, any one of those are reasonable. I mean, you probably use them all in the clinic.
No,
either
absolutely.
fulvestrant first, fulvestrant or an AI, non-steroidal AI, or even tamoxifen. those of us go old school.
I mean, it seems to me that the case you describe, and obviously I don't treat patients with metastatic disease, but it seems to me that's a perfect candidate for reintroducing a non-steroidal AI. I mean, she did well, and then 3-4 years later, I mean, she probably responded to the AI, but then you stopped.
Right.
So now,
No, I
in trying to
agree.
extend how many lines of therapy you can give before getting them to chemo.
Toxicity needs to be considered. A lot of my patients are celebrating the day they come off their adjuvant AI because of the arthralgias and side effects. And fulvestrant, I think, in my own practices, I see patients tolerate it a whole lot better. We do have an upfront study, right, of an AI versus fulvestrant.
But it's a small phase 2
It's a
trial.
small phase 2 study,
The
but it
first trial.
suggested that fulvestrant's a little better. At least you
At the
could say it
500, right, at the
reassures
higher
you.
dose,
Yeah,
right.
at the higher dose, that it's as good as, if not better
Yes,
than the AI.
as good as, yeah.